Military Medicine and WarDocs present a Ready Medical Force Special Collection. We speak with the authors of recently accepted journal articles addressing the key readiness issues in operational medicine and discuss the importance of their findings. Welcome to WarDocs, the Military Medicine Podcast. This show brings you a first-hand, behind-the-scenes look into the mission, unique opportunities, and deployed experiences of the entire military healthcare team. From state-of-the-art hospitals in the United States to the most austere environments across the globe, WarDocs has you covered.
Welcome to WarDocs. I'm Major General Retired Jeff Clark, and today our guest is Major Mary Ford, an infectious disease specialist serving at Brooke Army Medical Center, Fort Sam Houston in San Antonio, Texas. Mary is the lead author of the Military Medicine Journal's Article of the Year, Clinical Characteristics and Resistance Patterns of Pseudomonas aeruginosa, Isolated from Combat Casualties. Major Ford and her co-authors received this prestigious award during the February 2024 Association of Military Surgeons of the United States, most of us refer to it as AMSIS, the annual meeting. It was a great meeting, over 2,000 attendees, and that's where Mary and her team were recognized. Mary, congratulations and welcome to WarDocs.
Thank you so much, sir. I really appreciate it. I'm really happy to be here.
Yeah, well, we're very pleased to have you. So, Mary, why don't we start by just having you tell us a little bit about your background, how you came to become a U.S. Army Medical Corps officer, your specialty, why infectious disease?
You know, the short answer to that my family likes to tell is that at the age of 12, I read The Hot Zone. I started telling people that Ebola is cool. And my parents kind of thought to themselves, gee, what have we done to be cursed with a 12-year-old daughter who tells strangers that Ebola is cool? And kind of from that point on, I started saying that I wanted to do something in infectious disease. And, you know, the long story is a little bit more complicated. And I, kind of punctuated by a period of time where after watching my oldest brother, who's almost 9 years older than me, go through medical school and residency, I thought to myself, I'm not sure I am interested in working that hard. Maybe I can find some other path, not being a doctor, to kind of explore my interest in infectious disease. And ultimately, I just find the field so compelling for so many different reasons. And some of that has come as I have been, more exposed to it during my internal medicine residency. But a lot of it is really at the root of the kind of inequities that you can see exposed by infectious disease. I've always found tuberculosis really interesting. The care of people living with HIV is fascinating and really important. So I really, really love it. And, how I came to be in the military. So despite having no real military tradition in my family, both of my older brothers joined, long before I did. My oldest brother is actually an Air Force neurologist. And my middle brother spent 20 years as an Army Special Forces officer. He retired in September of 2023. So when I, came time to decide where I was going to go to medical school, I had seen my older brother go to USIS, and watching the experiences that both my brothers had, I just knew that, that was where I wanted to go to medical school. And that was the kind of patient population that I wanted to get to work with. And I'm grateful every day that I went to USIS and had that experience and continuing on in the Army now. So I love being an Army doctor. I love being an Army infectious disease doctor. I maintain that there is no better place to practice infectious disease than in the Army. We have the best patients, the best colleagues. We have great resources. So I feel very lucky.
Yeah, Mary, thank you for that. It sounds like your family may have started a tradition of military service. So
it seems like it, that's for sure.
Yeah, tell us, why did you and your colleagues do this particular research?
So the first thing I kind of want to highlight is who the group is that I did this research with. So this research was done on behalf of the Infectious Disease Clinical Research Program, or the IDCRP, which is a research kind of group that is located at USIS, actually. And they're this kind of multi-center, collaborative clinical research network that's really dedicated to reducing infectious disease threats in the military health system and improving the health of the warfighter. So that's what the IDCRP does. They just exist to kind of address infectious disease threats in the military. Really, essentially all of the research that has been done by the IDCRP is really trying to get evidence to change practice and policy in the DoD. And they have done some really meaningful work in the time that they've been around. The other thing I want to highlight about IDCRP is that, education and training is actually part of their central mission. So there is a huge amount of graduate medical education involvement in the IDCRP. Myself and a multitude of other trainees have really benefited by having access to this outstanding research group. People who just are true research professionals asking really interesting military relevant questions. So, nested within the IDCRP, the research that we did was within the TDOS research protocol. So TDOS is the Trauma Infectious Disease Outcomes Study. And TDOS is really, it was an observational study that evaluates short and long-term infectious complications following deployment-related trauma. TDOS is entering its 15th year at this point, so it's been around for a decade and a half. And prior to TDOS, there really hadn't been an effort to capture the kind of continuity of what trauma infections looked like from the battlefield all the way to, care back at our large MTFs and beyond, even into the VA system with some of our research collaborators. And so, while some would say, and it was really born out of OEF, OIF, right? That's, 15 years ago, that's what kind of prompted the need for TDOS. And, some people may say, oh, well, we're not really in an active conflict right now. Is this still something that's really important? And I think if you stop and think about it, especially with all of the conversation about, in our kind of conflicts, potential conflicts looking forward, we're talking a lot about the need for prolonged field care. This, ability to understand and mitigate infectious risks and then treat them when they arise is going to be even more important than it was in OEF and OIF. So I think that's kind of the underpinnings of the group that did this research. And, TDOS has been kind of continually trying to find information that can be actionable for the joint trauma system. So TDOS works really closely with the joint trauma system and has had a lot of kind of influence and work with some of the CPGs that the joint trauma system has published as well.
Yeah, that's good. That's very important. And thank you for that. Before we get into some of the details of your research, why don't you just share with us the bottom line up front? What do you want folks to remember from the research when they read your article or listen to this podcast?
I think for someone who may not be engaged in infectious disease clinical care on a day-to-day basis, the article could probably be pretty dense. And so I think the most important things to take away are that what we can do to limit morbidity and mortality from combat trauma infections is the basics, right? It all comes back to infection prevention and control and antimicrobial stewardship. And it can sound so silly to say to someone that maybe the difference is just when you're about to transport that patient or when you're going into that patient's room in the hospital, you're using that hand sanitizer, you're washing your hands. But for some of these infections, it really is that simple. And so I think that kind of, underpins why this research is so important.
Yeah.
The only other thing is that, when we think back to kind of why we did this research and why we want to talk about it, combat trauma infections have been a problem for as long as combat trauma has been in existence, right? And while we've seen a decreased case fatality rate since Vietnam, when we think about what's really hurting our, soldiers, sailors, airmen, and Marine when they get injured, it's the infections that they get when they come back. And so I think that's part of why, we really wanted to highlight these infections and highlight the principles of infection prevention.
Yeah. Yeah. Thank you for that. Incredibly important, and something that, being reminded to wash our hands is something that we all need to be reminded of, and how terribly important it is. So tell us a little bit about Pseudomonas aeruginosa. I went back and read a little bit in preparation for this, but if you would tell us a little bit about that bacteria and why it's important for military medicine.
Yeah, so Pseudomonas aeruginosa, kind of back to the basics, right? Gram-negative bacilli, but really for our purposes, the things that are important about Pseudomonas is that it's a really significant nosocomial pathogen. So it's one that people are picking up when they're in the hospital. And our study really highlights that as well. And it's often, when you look at studies, it's seen in patients who have had really prolonged hospitalizations, which is also the case for the patients in our study. Pseudomonas itself has multiple intrinsic mechanisms of resistance to antibiotics, with the ability to kind of acquire those resistance mechanisms rapidly when it's exposed to antibiotics. And so one of the reasons that we wanted to look at this bacteria specifically is because, as anyone who's taken care of these combat trauma patients knows, they are getting tons of antibiotics for long periods of time. They're exceptionally ill. Sometimes we don't know what's causing it. And so you're giving them big, broad spectrum antibiotics. And that antimicrobial pressure is exactly the situation in which Pseudomonas says, oh, hey, let me pick up these extra resistance mechanisms. And now all of those antibiotics you are using, not useful anymore. And more than just Pseudomonas, when we look at kind of combat trauma infections, especially once people are getting back to the United States, it's really these gram-negative organisms that predominate. And so a lot of the TDOS work has been on a variety of different specific gram-negative organisms. And Pseudomonas was the one that we chose to focus on.
Yeah. Well, thank you for doing that. And the fact that it's nosocomial, right? It's not something that happens at the time of injury. It's something that you pick up along the way, again, is very important for us in military medicine to focus on and think about. So if you could just summarize succinctly your research, tell us a little bit about your methodology results and what conclusions did you come to?
Yeah, absolutely. So, I think we've kind of discussed a little bit about, why Pseudomonas and how it can be difficult to treat. But based on that, we really thought it was important to look at the kind of clinical and epidemiologic characteristics and then outcomes of patients who had Pseudomonas infections during this kind of combat trauma period. So like I said, we did that using TDOS. And so it was a retrospective analysis of data that was collected prospectively. The patients who were enrolled in TDOS were enrolled kind of at the time of injury and then followed through their evacuation, from the combat theater hospital to LARMC and then back to the participating hospitals in the United States, which really at the time were the Walter Reed Army Medical Center and then National Naval Bethesda and BAMC. So those were the three places that in the US patients were followed and enrolled. We got, most of the kind of patient demographics and injury information from the DoD trauma registry. And then all of our microbiologic infection information came from TDOS. One of the most interesting things about TDOS is that, and part of what made this study possible is that these patients were enrolled and all of these cultures, the Pseudomonas that we grew back in 2009, 2011, whenever it was, those cultures were physically saved in a repository so that for our study, we were able to pull those out of the freezer, re-isolate the organism, do the molecular testing to identify it, and then repeat antimicrobial susceptibility. So we had all, took this data that had been collected a long time ago, but we were able to kind of confirm and really do some new things with it. So when we look at our results, of the about 2,600 patients who were enrolled in TDOS, ultimately 146 of them with 374 total Pseudomonas isolates were included in our study. So about 6% of the patients had Pseudomonas infections, and we looked only at wound infections and at bloodstream infections. So, patients who were really, really sick. And when we look at the kind of demographics of these patients, they were all male. Their median age was 24 and their median injury severity score was 33. So the injury severity score, for people who are listening who aren't familiar with it, it's kind of an anatomical scoring system that provides an overall score for patients who have multiple injuries. So a score of 15 or higher is basically considered a polytrauma or a severe trauma. The median ISS for our patients was 33. So these were young, exceptionally ill, patients. The other things that we found, that I think are important to highlight. So these folks had a median ICU stay of 12 days, a median hospital stay of 59 days, most of them 2 months or more. And then, really going back to that Pseudomonas being a nosocomial pathogen, the median time from initial injury to isolation of Pseudomonas, so from when they were injured to when we actually found the Pseudomonas, was 14 days. So these people had been away from the battlefield for a long time. This is really, this was an infection that was coming in the hospitals, which is consistent with the data that we have for Pseudomonas from the civilian population as well. We also kind of broke it down and looked specifically at patients who had multi-drug resistant Pseudomonas, which I think is an important question for clinicians. Up front, if I think someone's going to have a Pseudomonas infection, do I need to treat them with something that can treat a multi-drug resistant organism? Or is our kind of run-of-the-mill empiric antibiotics, are those going to be okay? And, what we found is that we actually only had MDR isolates in 14 patients, so about 10% of our population. 6 of those patients are people who initially had drug-susceptible isolates. And then as they had all those antibiotics when they were in the hospital, very sick, they developed a resistant organism, which fits with what we know about Pseudomonas. And the patients who did have MDR Pseudomonas were even sicker than our general population. So they had even longer ICU stays, even longer hospital stays, more days spent on the ventilator, just really sick. And then the last key piece, trying not to get too much into the weeds, is really looking at the microbiologic data. And kind of upfront, the highest susceptibilities we had, so the highest percent susceptibilities, were really to aminoglycosides, which, as we know, are super toxic old antibiotics that we don't like to use if we can help it. And then anti-pseudomonal cephalosporins, which are things that we use pretty routinely for, kind of empiric treatment. When we looked at our MDR isolates, over 90% of those isolates were resistant to fluoroquinolones, to piptazo, to carbapenem, the things that we think about as good drugs for a drug-resistant organism or a gram-negative infection were just things that we can't use. The only things that we could still use really were amikacin and colistin. So again, two really toxic old antibiotics. So it just highlights, when we burn through those newer, less toxic antibiotics, we're left with some really unpalatable options. One of the key points, I think, is really that 14 days to isolation. This is consistent with Pseudomonas being a nosocomial pathogen, and it's really impacting the people who have high healthcare exposures and a ton of antimicrobial pressure.
Yeah. Mary, thank you for that. I guess, and as we wrap up, if you could kind of tell us one more time, what's the bottom line? What do you want folks who listen to this podcast and read your article to walk away with? What's the elevator speech version?
Yeah. So, although we've seen a lot of advances in combat casualty care with our recent conflicts, infectious complications are really still the primary driver of morbidity following medical evacuation, right? This is what is hurting our people once we get them out of theater. And if we're put into a situation where we can't get them out of theater, this is what's going to really be a problem. So, we're even seeing this now with some of the combat trauma infection data that's coming out of Ukraine, like a current conflict. There have been a few things published by our team at RARE, by some of our physicians who are at, our infectious disease physicians who are at LARMC. And we know that, when an area is in conflict, that puts extraordinary pressure on medical infrastructure, which can really lead to gaps in infection control. So, if I could hammer home anything, these antimicrobial stewardship and these infection prevention and control principles really matter. And, when we are in times of conflict where our systems are under pressure and we are understaffed and under-resourced and everyone is busy, fall back on those basics, right? These are the things that are going to matter, the things that don't necessarily take a lot of resources, but can have a huge impact for, our service members.
Yep. Yeah, the basics are the basics, and that's why we call them the basics, right? Because that's what we should be doing every day. Thank you, Mary.
Exactly.
And our guest has been Major Mary Ford. Mary, congratulations to you and your team for being awarded Military Medicine Journal's Article of the Year. And thanks for being a guest on WarDocs.
Thank you so much for having me. It's been great.
It's great rundown. Thank you. And I encourage all who have not yet read Clinical Characteristics and Resistance Patterns of Pseudomonas aeruginosa isolated from combat casualties in the March-April 2022 edition of Military Medicine to do so. If you're already an AMSIS member, you already received this outstanding journal and can easily access this article and many of the other wonderful articles that Military Medicine produces. If you're not an AMSIS member, I encourage you to do so. It's a great organization. The Journal of Military Medicine is a great journal. I encourage you to go to the website, www.amsus. Again, thank you all for being with us, and may God bless.
Thank you for listening to WarDocs. We sure hope you enjoyed it. WarDocs is a nonprofit organization supported by donations from listeners like you. Please follow and subscribe to our show on whatever platform you consume your podcasts, and rate and review this episode, and share the show with your contacts on social media. Find out more information about our show, our guests, and how to become a member of Team WarDocs on WarDocsPodcast.com. Thank you for your support. If you like war stories and medical drama, WarDocs has you covered. Spread the word.